Hello, friends. Matthew Zachary here. You've been told that the American healthcare system is broken. It isn't. It's working exactly as designed. Delays, denials, dehumanization. For decades, it's been profits over patients. You need proof? What's the first question they ask you? What insurance do you have? That tells you everything. And it isn't just big health insurance. It's the American Medical Association, it's labor unions, it's employers, politicians from both sides, and even the IRS. Yes, the IRS. They built it this way. And now it's time we, the patients, rig the system in our favor. Here's the prescription. We, the patients, understanding, navigating, and surviving America's healthcare nightmare. My new book by me, Matthew Zachary, a 30-year brain cancer survivor, the founder of Stupid Cancer, the host of this podcast, Out of Patients, and co-founder and CEO of We the Patients. Pick up your copy of We the Patients today wherever books are sold, or visit wethepatientsbook.com to learn more.
Insurance isn't one size fits all. That's why customers have enjoyed Progressive's Name Your Price tool for years now. With the Name Your Price tool, you tell them what you want to pay, and they'll show you options that fit your budget. So whether you're picking out your first policy or just looking for something that works better for you and your family, they make it easy to see your options. Visit Progressive.com. Find a rate that works for you with the Name Your Price tool. Progressive Casualty Insurance Company and Affiliates. Price and coverage match limited by state law.
Hello, friends. Welcome back to Out of Patients. In science, progress isn't just slowed by what we don't know. It's strangled by systemic barriers built on bias, bureaucracy, and buried history. Then there are the gates that guard access, diminish diversity, and dampen discovery. So, when barriers need breaking, we send in Oliver Bogler. Here is the latest dispatch from Season 2 of Standard Deviation. Take it away, Oliver.
One morning in Los Angeles, a man was hit by a car. He was taken to the emergency room. His injuries turned out to be survivable. The trauma team stabilized him, and then, as they do, they scanned him, looking for internal bleeding, for broken bones. They found something else, a mass in his colon. A few days later, that man, a patient Dr. Belinda Waltman would come to call Mr. L, was sitting in a clinic across the city, being told he probably had cancer.
He'd actually had a car accident and had an incidental finding of this, basically, colon mass. So he had been there for other reasons, and in his words, he had said this is maybe a blessing in disguise. So he'd had the CT scan that revealed the colon mass.
A blessing in disguise. That's what he called getting hit by a car. This is a man who has just been told he may have cancer, and his response is relief. I'm Oliver Bogler. Today on Standard Deviation, our season finale. For 5 episodes this season, we've been pulling on a single thread, the hidden curriculum of science, the unwritten rules about who gets to publish, who gets read, and who gets believed. Today, we take that question out of the lab and into a clinic. What a doctor sees can matter as much as what a lab finds, but only if it gets published. Dr. Belinda Waltman is a primary care physician in Los Angeles County, and her clinic is a unique one.
I do primary care for the underserved in safety net settings, currently in a very large safety net setting, but I've worked in small free clinics as well. And over the years, my clinical practice has evolved into a really, really unique and specialized setting, which is I do expedited malignancy workups in the outpatient setting. So basically, these are patients who are new to our system, who are coming in either with suspected cancer because of symptoms, or they've actually seen something on imaging and they've said, look, you either don't have insurance or you don't have good insurance, so go to your local public hospital system.
You don't have good insurance, so go to the public hospital. That is a sentence somebody says to a person who might have cancer. Belinda's job is what happens next. She has to get them from suspicion to diagnosis fast. But too often, the diagnosis is only half of what is in the exam room.
What transpires in those visits and what you learn so quickly, even in one visit, about not just what they're going through medically, but the social context of what's happening and how that is additionally destabilizing is what's so powerful.
Back to Mr. L. He's been told he probably has cancer, and here's what he wants to talk about.
He's honestly thinking about his day-to-day survival, and so that's where we started talking about his work and how he was struggling with these days missed, and what that was going to look like for him. And how difficult that is to make those decisions. Effectively, the patients that I care for, who are these hardworking, low-income patients who are mostly things like essential workers across our cities, who don't always have jobs with good benefits. They may not have paid sick days or paid leave. They are faced with this question of, can I miss another day of work to get the diagnosis and ultimately to get treatment when I'm not going to get paid? And what is that going to mean for my day-to-day survival in terms of having enough food and ultimately paying my rent?
So, you just said something incredible. You just said he's concerned about his day-to-day survival. The conversation is around cancer, but that's not what you're talking about. You're talking about economic survival.
Yeah, and that's the theme that I see, and I think so many of my fellow colleagues see, that there are these different layers of survival.
Different layers of survival. There's the cancer, and then underneath it, there's the rent.
When you're barely surviving day to day, not just the paycheck to paycheck, but you're spending your days, even though you're working, and in some cases working multiple jobs, to have enough money to pay your rent and get food and have transportation. If that is destabilized, it's so hard to focus on anything else. And so, again, some of these conversations with patients are around, what is this going to mean if I have a cancer diagnosis and I'm going to need chemo for weeks and weeks and weeks, or I'm going to need this big surgery or whatever it is? How can I possibly make that happen and make that work in my life?
Belinda works in what some call the medical safety net. It's one of those phrases that sounds softer than the thing it describes. The Institute of Medicine defines it as those providers that organize and deliver a significant level of health care and other needed services to uninsured, Medicaid, and other vulnerable patients. Why do we need it?
Safety net, it's true, it's a broad term. It's basically, these are patients who are either uninsured and or have health coverage like Medicaid that typically pays hospital systems less than commercial insurance. There are many clinical systems and settings across the country, like different private practices and whatnot. Not all of them, who may not accept a patient who doesn't have insurance.
A couple of years ago, Belinda began to think about how she could alert more people to what she was seeing on a daily basis. Take, for example, another one of her patients, Mr. M.
So he also had somewhat of an incidental finding. He had presented to the emergency room with abdominal pain and a new onset diabetes. And he was actually found to have basically a relatively rare neuroendocrine pancreatic cancer and a number of complications from that cancer. So he was quite sick when I saw him, although it also took quite a while to get to a diagnosis.
Mr. M was undocumented. He had been in this country a long time. And here's the part that surprised me. It is not that his cancer care was unavailable. Los Angeles County took care of that. It's what came with it, or rather, what didn't.
At that point, he was not eligible for the state Medicaid program. And so he was one of our uninsured patients. And when we're thinking about kind of the ancillary resources like food resources, they're just a different set of resources, the more local ones, versus like the, food stamp program that you might qualify for at the state or federal level. I've been fortunate to work in these safety net settings in states across the country that are progressive and that value human life regardless of immigration status. And so they provide care for patients regardless of their coverage, and regardless of things like, what language they speak or where they come from. And I know I'm fortunate to work in those settings. It's not the case everywhere. But in this case, his medical care was all covered, but there were all of these other things that were more challenging.
His medical care was all covered. We can treat the tumor. We cannot feed him. We spend so much energy arguing about who deserves a doctor that we skip right past the question of what a doctor can actually do for someone who has no food, no rent, and no bus fare. Belinda asks, that's the part of the visit that undoes her.
I think the food insecurity is a good example. Many of my patients, and I don't have the exact number, but anecdotally, the majority, more than half of them, are food insecure. And this is a question that we ask everybody. And there's actually like a validated screening tool. But it's also, I think, in that section of what we call the social history, where we're kind of getting at the non-medical things that are leading part of their presentation, living situation, work situation, substance use, that sort of thing. It's my kind of opener to this bigger view into what's going on, because so many of my patients are really stoic. Again, they're hardworking. They don't ask for help. They're not asking for any sort of charity. And yet when you say, in the last 12 months, have you run out of money for food? Or, oh, I'm hearing that you're not currently working because of this. Does that mean that you have enough money for food? There's usually this pause, and then it's like, no, actually, I don't.
You're their doctor. Why are you talking to them about food and housing?
Yeah, well, as you can imagine, these things have a huge impact on health. I mean, there's a whole discipline. They were called the social determinants of health. Now they're more commonly referred to as health-related social needs. These are the things outside of your own sort of clinical conditions, but the things in your environment oftentimes that you can't change that have a huge impact on your health. The unhoused example. If you are homeless and you are day-to-day going shelter to shelter with your stuff, do you really have the time or the energy or the resources to focus on your chronic disease? Again, if they are transportation insecure and they've lost their car or they never had one, or they can't take public transport because they're too sick, how are they going to get to those chemo appointments? And again, we have ways to support that, but you have to ask.
But you have to ask. And if you don't ask, if you never build the question into the visit, into the chart, into the record, then as far as the system is concerned, it never happened at all. Hold on to that. We'll come back to it. And what happens when you can't fix it?
Food is an easier example than, like, say, housing. I mean, if someone is at risk of eviction because they're not able to work and pay their rent because they're undergoing treatment, and even if somebody qualifies for disability, it doesn't pay their whole salary, and oftentimes it doesn't cover all their bills. And so there are many fewer options that we have to house somebody. And this is not unique to where I practice. I think across the country, that's really challenging. And then you kind of feel like your hands are tied.
And a delay isn't an inconvenience. In her clinic, a delay is a clinical event.
I mean, a delay could be significant. There are, depending on how advanced somebody's cancer is when they diagnose. Oftentimes, I am seeing patients who are stage 4, the most advanced. They've got metastatic disease. You can miss a window. Like, you can have somebody who can clinically decline and have a poor functional status where they're not going to be a chemo candidate. Or maybe what was locally advanced disease that was resectable, if you wait 2 months, it's no longer going to be resectable. And that does happen.
You're not going to say, but I will. It could kill them.
Yeah. And they know that.
Belinda documented Mr. M's health-related social needs in his chart. But health records are private, protected. So Belinda also added Mr. M to the collection of stories she'd been carrying.
So I'd been mentally collecting these stories for a long time, probably like a year or two, and had been thinking about I'd like to get them out there and publish them. And again, we've talked about a lot of the themes. Basically, patients undergoing cancer workup who are facing continuing to work to live or taking time off of work to get treatment to live.
Belinda wanted to create a different kind of record, one that she could share with the world, and she couldn't get it onto the page.
I was having a hard time kind of distilling that message and thinking about the right audience and how to also instill a little bit of hope, or how to make it not just a depressing story, that our hands are tied, that sort of thing. And I was getting stuck.
This is where I want to slow down, because it would be easy to hear that as an ordinary case of writer's block. It isn't. She is a full-time clinician running Medicaid programs and treating patients in the public safety net. She's not a researcher, she has no lab, no grant-writing staff, no professional pipeline into the journals. And she is trying to break into the Journal of the American Medical Association, JAMA, a top journal in American medicine, home of the latest blockbuster clinical trials.
I might have been unique in that I'm not a scientific researcher. I'm not doing research, but was still looking to submit and publish something in an academic journal.
This season, we've talked about the machinery of that room, the prestige hierarchies, the commercial publishers with profit margins that would make a tech company blush, the unwritten rhetorical rules you're simply expected to already know. Belinda had the truth. She did not have the recipe. What she had instead was a colleague who told her about a program.
I had known of Angela's incredible work through another science colleague, and I had heard about this JEDI award, which is basically an opportunity to submit a project that you're working on, that you basically need this kind of support to get it to the next stage. And so ended up applying for the JEDI award, meeting Angela, sharing the ideas, and was fortunate enough to be given the award to get to work with her. We had this amazing, creative period, and all the support she offered, kind of this ability to go back and forth with these different drafts and ideas to get it to fruition, to be able to submit it. I mean, she's so masterful in so many ways with all of those things, like the big picture, the wordsmithing. I would send her a draft and get something back that was like, gosh, that's such a better way to say it.
And what was Angela actually teaching her? It was how to balance emotion and fact. It was writing so that the stories Belinda was telling would be read the way they were intended, as a record of human experience that showed both the medicine and the person.
For me, it was great. That's what I've been looking for. I needed that guidance. And it very quickly made so much more sense. I wanted to be thoughtful even again in that period about having a U.S. citizen patient and an undocumented. Like, we were looking for this balance. We didn't want this to be a political piece. I wanted this to be just for my medical colleagues to think about and increase awareness around these issues that, again, we are privy to if we ask about them. And so that process was great. And I think she helped me balance it and highlight the parts that matter, again, without sounding too trite or, without these anecdotes being sing-songy. Like, we wanted them to be the essence of what the patients had shared with me.
Without the anecdotes being sing-songy. That's a craft note. That's an editor teaching a clinician that the difference between a piece that gets published and a piece that gets deleted is not how much you cared. It's whether you let the reader feel manipulated. And then there was the title.
We were word playing toward the end, the title, because I'd been trying to think of something that sort of encapsulated both the cancer and the working piece, like the survival piece. So we'd been playing around with things like living on the edge. And eventually we were thinking that margins could be a good word that has this double meaning. Obviously, in cancer, positive margins or wanting to have clean margins, and then our patients who are vulnerable and are marginalized. And so the final title actually that I had sent her was When the Margins Matter. And we met that final day, and she said, I just have one edit. It should be the margins matter, because it's not about when, they always matter.
One word. That's the whole hidden curriculum in a single edit. When is a story about a moment. The margins matter is a story about a fact. Same doctor, same patients, same suffering. One word, and it's an argument. In December 2023, The Margins Matter was published in JAMA. So, what does a JAMA paper actually change? Not the policy. Not yet. If anything, since she wrote it, the ground has moved the wrong way.
When I wrote the article, it was a different time. It was 3 years ago. But now even more with what's happening with the tremendous Medicaid cuts from HR1 and basically like the dismantling of our social services. And I'm not talking about for undocumented patients. I'm talking about U.S. citizens who are struggling to keep their Medicaid, and it's going to get more difficult, and all of these other things are being cut. Like, that's the really hard part, that it's hard to provide good medicine. And again, the safety net is sort of crumbling.
So no, it didn't fix the crumbling safety net or restore Medicaid cuts. But it is making a difference one person at a time. A few months ago, Belinda was seeing a patient.
This was a really wonderful patient I've been caring for, who had shared he's a construction worker, and same story, being faced with the work situation as he undergoes a diagnosis for what is now metastatic prostate cancer. And so we had talked about his situation, and we tried to figure out with our social worker a couple of resources. And I ultimately handed this to him on the way out of clinic one day and said, I with my patient's permission, sometimes I write about them, and here are a couple of stories. I just wanted him to feel heard, and I wanted him to know that he wasn't alone, because I got the sense that even though I had tried to validate what he was sharing and I tried to normalize it, he really was feeling alone.
She printed out the JAMA article, handed it to a man on his way out the door. Then she didn't see him for a while.
The next time we had a visit and we spoke, he broke down and he said, in tears, I read what you gave me, and I am that patient. That is exactly my situation, even though it's slightly different, but similar. And he said, I feel seen.
I am that patient. A man in a public hospital clinic in Los Angeles, holding a paper from the Journal of the American Medical Association, a journal that was never written for him, and finding himself in it. I asked Belinda what the piece actually made possible, and she answered it with a phrase from her own profession, one that stopped me cold.
I think it's the impetus. The powerful part about writing and getting something out there that's honestly really challenging is you can have all the ideas in the world and you can have great conversations, but in medicine, there's a phrase in terms of like our clinical documentation. If you didn't document it, it didn't happen. That's like a medical legal thing. But it kind of in this other avenue, being able to get something out there and have it on record and have people react to it and putting it into the ether, I really do think is so important.
If you didn't document it, it didn't happen. Every doctor in America knows that phrase. It's a warning about liability. Write it down or it doesn't count. But to listen to what she's doing with it, she's turning it around and pointing it at the whole system. The empty fridge, the eviction notice, the bus fare he doesn't have, the pause in the exam room. If nobody documents it, if nobody publishes it, if the people who live it can't get past the gate, if the doctors who see it don't have a staff of writers to help them say it in the right dialect, then as far as the record is concerned, it didn't happen. That's the whole season, right there. Belinda isn't done. She's building something new.
So I'm actually in the process of setting up a nonprofit called Essential Voices that is intended to be a storytelling collective with different kinds of media that I'm hoping will basically highlight, thinking it will be essential workers stories about them not being able to get essential care, and not just healthcare, but really just having their basic needs met, despite, in many cases being full-time workers who hold up our communities. And I'm hoping that through these efforts, we'll be able to not only maybe put faces to names, but just infuse more humanity into this, so that, I think when you hear a generic tagline, it's one thing. But when you see the specifics and you hear a person's story and you realize, oh, that's in my community, or I may not be suffering, but my neighbor is.
And when I asked her what she'd learned from the whole thing, the patients, the writing, the editing, all of it, she didn't say anything about publishing.
This whole thing taught me, and part of that piece was just about asking questions. I think realizing that people really are suffering on a day-to-day basis, and feeling more free to ask your whomever it is, your neighbor, your bus driver, whatever it is, how their day is going. And obviously depends on the setting, but just, I think, being aware of what's happening and thinking about ways as a community that we can support each other.
That's Belinda Waltman, MD. Her essay, The Margins Matter, is in JAMA, link in the show notes. And that's our season. Over 6 episodes, we've gone from structural biology benches in Chapel Hill to biophysics labs in Canada to a safety net clinic in Los Angeles. And the thing that connects them is not a technique or a discipline. It's a question about who gets to speak. Science likes to think of itself as a meritocracy, as a machine that runs on data, indifferent to who's feeding it. But data doesn't speak. People speak. And when the unwritten rules filter out the first-generation scholar, the parent, the safety net clinician who's seeing something nobody's written down, we don't just get a less diverse science, we get a less accurate one. Think about what stays in the drawer if these papers never get out. No wearable bioreactor, no demonstration that you can restart a developmental program to regrow a limb. No R01 for a talented early career scientist, and so no lab and no work on how cancer progresses. Careers lost, discoveries never made. And that's only the science we can name. The harder loss is the science we can't, the questions never asked because the person who would have asked them wasn't in the room. Remember the pulse oximeter, less accurate on darker skin, used to triage patients in a pandemic, with nobody present to say, wait, this may not work for everyone. And the man in the crosswalk in Los Angeles who thought getting hit by a car was the best thing that had happened to him all year. It isn't just careers that go missing, it's the questions and everything that follows from them. The JEDI program says it edits scientific writing. It does more than that. It helps creative, dedicated, curious people add their knowledge to the record, making science stronger, making the world better. I'm Dr. Oliver Bogler. This is Standard Deviation on the Out of Patients podcast network. This episode and our entire second season was produced with the generous support of the Life Science Editors Foundation. Thanks as always to Matthew Zachary for his support. Special thanks to Dr. Angela Anderson, Dr. Brandy Matson, and all the JEDI volunteers who give their nights and weekends to keep the doors of science open.